In this part of the discussion or the program, we will be discussing mainly about the oxygen therapy, the various devices which we are using in providing oxygen therapy, and the scenarios which we get most commonly. First of all, oxygen is a drug and it doesn't have any substitute. Last few days, when the scarcity was there at its peak, we came to know about the importance about the oxygen, and we also came to know that how important it is to use it in a proper way, in a controlled way. When appropriately used, it is extremely beneficial, but when misused or abused, it is potentially very harmful too. The clinical objectives in oxygen therapy is first of all to correct hypoxemia. Second is to correct or minimize the symptoms of hypoxemia. Suppose a patient is having hypoxemia and that has led to disorientation or confusion or weakness, then those things shall get corrected once we start our oxygen therapy. And third main objective is to minimize the cardiovascular effects of hypoxemia. Whenever a patient is hypoxemic, his sympathetic drive goes up, he might be having increased blood pressure, increased heart rate. So once we start administering oxygen and we are giving it as a therapy, these cardiovascular side effects of hypoxemia shall settle gradually. When we call that the patient is hypoxemic, whenever the saturation is going less than 94% or PaO2 by ABG is less than 60 millimeters of mercury on room air, we say that the person is getting hypoxemic and we should start our oxygen therapy. The target in oxygen therapy is to keep saturation levels more than 94% and on ABG, the PaO2 more than 60 millimeters of mercury. Few specific populations, like if the patient is pregnant, then this target goes a bit higher and our target goes from 94 to 96%. If the person is having a history of COPD, then the target gets lower and it goes from 88 to 92%. So we have to individualize according to the patient कि उनकी requirement कितनी है. Assessing a patient includes 2 or 3 things. Mainly, first of all, we should clinically assess the patient and we should see whether the patient is having tachypnea. Is there any tachycardia or hypertension is there? And how is the patient's sensorium or mentation? Is he getting restless, or if he is getting confused, or if there is some signs of disorientation, then it means that patient is getting severely hypoxemic. Common monitor which all of us are very used to is pulse oximeter, and we use it very frequently in all different setups, including HDU, ICUs, OTs, everywhere. And the last one, which is not available everywhere, but it is preferred mode of monitoring, is ABG, that is arterial blood gas analysis. Now, coming to various devices, why different types or different oxygen delivery devices are there, or why is it needed? First of all, it is needed that we have to decide that what is the appropriate oxygen therapy, and we have to administer using that device. Then, over a period of time, we come to know about the progress of patient, and we can communicate easily that now this patient is on nasal prongs, or he is requiring mask, or he is requiring NIV support, or he is requiring high flow nasal cannula. So it tells us about the progress of the patient also and how he is behaving. It helps us in escalating or de-escalating the oxygen therapy. It helps us to avoid oxygen toxicity, and it also helps us to avoid wastage of oxygen, which is very important. The devices and the methods which will be discussed over the next few minutes or hours will be nasal prong, face mask, Venturi mask, mask with reservoir bag or non-rebreathing mask, high flow nasal cannula, and non-invasive ventilation or BiPAP and CPAP therapy. In this lecture we will on, or in this discussion we will be primarily discussing about nasal prongs, face mask, Venturi mask, and mask with reservoir bag and non-rebreathing mask. Dr. Tapas will be discussing about high flow nasal cannula, and Dr. Divya ma'am will be telling us about BiPAP and NIV therapy. The initial the initial five methods of oxygen therapy, that is nasal prong, face mask, Venturi mask, these don't require tight seal and they are easily tolerated by patients. Coming to the first device, that is nasal prongs. Using nasal prong, we can give oxygen from 24 to 30% of FiO2. This is the device which is used as the base or the minimum oxygen support. Good part of it is that it doesn't hinder in eating. Patient doesn't feel claustrophobic. Patient can drink, he can speak, he can communicate. It is very useful as a stopgap arrangement while patient is having food or the physiotherapy is going on, or if we have to move patient for investigations like X-ray. The flow rate which we shall be using in nasal prong is 2 liters to 4 liters per minute. A flow higher than 4 liters per minute, or say more than 5 liters per minute, causes lot of discomfort to the patient, and the cold oxygen which is going inside the nostril causes a jet effect which is very uncomfortable for patient because of the crusting which happens. This high flow leads to lot of crusting in the nasal mucosa, and if suppose we are giving oxygen for long periods of time, then it may also cause bleeding from the nasal mucosa. So we should always keep in mind that whenever we are giving oxygen from nasal prongs, we are giving at rate 2 to 4 liters per minute or maximum 5 liters per minute, not more than that. Second one is the face mask. This is the oxygen device which most of us are very used to, including the nursing staff, our interns, everybody is very used to this device. This is also known as Hudson's mask. This can be used to provide oxygen from 30% to 50% of FiO2. It has vents on the side from which the exhaled air goes out. In this mask, we have to always keep in mind that we should not give it less than 55 liters per minute of oxygen or fresh gas flow from this mask. Because what happens that most of our COVID patients are having some sort of respiratory involvement, lungs are involved, and we are giving oxygen to the patient. So whenever we are giving less than 5 liter, the exhaled air doesn't goes totally out of the mask. There might be entrapment and the patient might rebreathe what he has exhaled. So whenever we are using this mask, we have to keep in mind that the flow should not be less than 5 liter per minute. Coming to the next device, it is Venturi Mask. Venturi Mask comes in different color codes and it provides different oxygen concentrations. The Venturi Mask is having a connector at the base, which is of either blue color, white, orange, red, or green. And depending upon the color code, it has a different structure, which means there is different size of port in this which entraps air from the atmosphere. The Venturi mask provides different concentration at different this thing color coded masks. We can go as high as 60% when we are using the green colored one, but this will also require 15 liters of fresh gas flow. As you can see, there is this is also mentioned here on the base of the connector, that what is the flow which will be required to provide the oxygen which the device will provide. Like this green one will need 15 liters per minute and it will provide 60% FiO2. When we are using this blue mask, it will need 2 liters per minute of fresh gas or fresh oxygen, and it will provide 24% oxygen. This works on Bernoulli's theorem. What it does, the oxygen is passed through a narrow pipe, and then due to the high pressure which is generated, it entraps air from the environment, and the fixing and the mixing of the entrapped air to the oxygen is fixed for each device. So the oxygen which is delivered to the patient is fixed. This is the only device where the oxygen delivery is not dependent upon the patient's effort. Rather, it is dependent upon the device which we are using. Next mask is the mask with a reservoir bag or a non-rebreathing mask. This is our savior at the times when we are not having any specialist around us, or we are not having an IV or BiPAP. This mask is the device which can be used to provide highest oxygen concentration without backup of expertise with us. In this, the fresh gas which we are using is from 8 liters to 15 liters per minute. And depending upon the fresh gas, the FiO2 will be delivered to the patient. We can provide as high as 90 to 95% of oxygen to the patient. The structure of this mask includes two valves. One valve is here at the mask. Whenever the patient exhales, this is a one-way valve. It is having a one-way valve. Whenever the patient exhales air, that air is pushed out through this hole to the outer environment. And then there is one more valve here, which is connecting the bag to the mask. This valve allows movement of oxygen from the reservoir back to the mask. So whenever patient
Five
is,
more minutes, Prateek. Sorry, 5 more minutes.
okay, sir. So whenever the patient is having, breathing in, the oxygen gushes out from this, gushes in from this reservoir back to the mask, and patient is inhaling highly enriched concentration of oxygen. Next device is high flow nasal cannula. This will be dealt later by Dr. Tapas. So concluding, there are mainly devices which we are using. The nasal cannula, we can use it at rate of 2 to 4 liters per minute, and the FiO2 which will be delivered will be 24 to 30%. The face mask, 5 to 8 liters per minute of fresh gas flow, and the oxygen delivered will be 30 to 50%. Venturi mask, 4 to 12, depending upon the device which we are using or the mask which we are using, and the oxygen concentration will be 24% to 60%. And then non-rebreathing mask. In this, if we are using very high flow of oxygen, then we are able to provide around 90 to 95% of oxygen to the patient. Points to remember: the humidification is necessary in all devices and must in the situation whenever we are using more than 4 liters per minute flow of oxygen. There should be a SOP in our HDO or ICU wherever we are using devices regarding the cleaning and maintenance of the humidifying chambers. Once the water inside the chamber is below the minimum mark, we should always ensure that the whole bottle is emptied and filled with fresh water, and we are not topping it up. Humidifier should be washed in mildly soap water, rinsed with clean water, and dried before reuse. And once a week for the same patient and in between patients, all components of humidifier should be soaked in mild aseptic solution for about 30 minutes and rinsed with clean water and dried. If coming to the decision-making tree, if the patient is having mild disease and his respiratory rate is settled, but his saturation is below 94%, then in these patients, we should always start our treatment with nasal cannula. In using a nasal cannula, there are two benefits. First of all, the patient is very comfortable, and second is a N95 mask or another mask can be applied over it also. If the patient is having moderate disease and his respiratory rate is more than 24 per minute and his saturation is less than 94%, then in these patients, When we are seeing that he is having obvious tachypnea, we should start with masks. We can use Venturi mask also, or we can use non-rebreathing mask also, and combining it with self-proning or rotating to the side, we can provide optimum oxygen therapy. If the patient is severely hypoxemic and he is having respiratory rate of say more than 30 per minute, and in spite of this high respiratory rate and tachypnea, if his saturation is not maintaining more than 90%, then these patients are having severe disease, and these patients should be started with high flow nasal cannulas or NIV therapy. And if we are able to combine it with proning and rotation, it's well and good. So we have prepared a scenario. We'll just go through this very fast. Say a 65-year-old male patient with complaint of fever for last 3 days and RT-PCR positive status has come to us, and he's having breathlessness for last 1 day. On examination, we found that he's having respiratory rate of 28 per minute and his saturation is lingering around 92. Then what will be the ideal mode of support which we should start? We can start with nasal prongs or masks. Suppose we have started mask at 5 liters per minute and we see that now the patient respiratory rate is 32 per minute and his saturation is around 88%. Then we will have to step up and we will have to go to non-rebreathing mask and we will have to start around 12 to 15 liters per minute. If after 1 to 2 hours of therapy, a ABG is done and we find that the saturation is at 90 and the ABG is showing a marked hypoxemia with PO2 54 and PCO2 52, then we will have to go to the high flow nasal cannula therapy. And if with high flow nasal cannula, we find that now the patient's PCO2 is also building up and the patient's PO2 is not maintained, then we will have to increase the flow in the high flow nasal cannula also. Suppose we are giving 100% oxygen and with 60 liters per minute of flow in high flow nasal cannula, and then we repeat ABG, now we can see the respiratory rate has settled a bit and oxygenation has improved with a PO2 of around 80. Then we can combine with self-proning, and with due course of time, we can taper down our therapy and continue other modes of therapy like the pharmacological therapy which we are giving to the patient. Gradually, the de-escalation of the support can be done. Suppose if we have started high flow nasal cannula and still the patient is not responding with high flows also with 60 liter per minute and the oxygen is still the oxygenation is not maintained and his PCO2 is building up say to 67 millimeter of mercury, then we will have to go for assisted ventilation or the device where we are going to assist the patient also. Then comes the role of our NIV or BiPAP therapy. If the approval is there, well and good, and if the worsening is there, then finally we will have to go for invasive or intubation and ventilation. So stay safe and stay healthy.